Thanks. You've heard many of the themes that I'll touch on, but I want to just start by pointing out something that's probably obvious to many people. Whenever anybody is diagnosed with breast cancer, one of the first questions that they ask is, why did this happen to me? And as you just heard, only a minority of them are attributable to the known inherited abnormal genes or mutations that we see in some of our smaller populations. So the question, why did this happen, has been an intriguing one. Related to that are a couple of other important global observations that you've probably heard about, which I'm going to try to tie together for you. That is, why is breast cancer, along with several other cancers, more common in Western and affluent societies? Why are they linked to some degree to calorie consumption and to obesity? And why is it that women get estrogen receptor positive breast cancers after menopause when most people are used to considering that estrogen levels actually fall at menopause? So I've listed a series of seemingly unrelated questions. With my very close collaborator at Cornell, across the street from Memorial, Andy Dannenberg, we've been pursuing these questions both in animal models of breast cancer. We have mice that actually start out healthy and develop breast cancer, and we've manipulated these mice to duplicate or recapitulate what happens in humans. We make the mice menopausal, we overfeed the mice, and amazingly, and as you might expect, with menopause and with excess calories in their diet, especially certain kinds of fatty acids, we see an excess of breast cancer. So we've taken those observations and we've dissected in the mice the question, what is actually happening in the breast? Why are they developing these cancers? And then we've gone back to humans, to our patients, and we're actually looking at the normal, healthy breasts that we are able to obtain from people who have operations for non-cancer reasons. And we are beginning to unlock what we think is at least one possible explanation for the risk of post-menopausal estrogen receptor positive breast cancer. And what it all ties into is broadly inflammation. So it turns out, as many of you will have seen over the years, that if people take aspirin, they may lower their risk of breast cancer. The data for that is not conclusive. I don't want to overstate it, but there have been some clues. We've modeled that aspirin and drugs like aspirin can prevent breast cancer in the mice. And so what we've recently discovered is that there are structures in the fat that are very, very inflammatory, and there are not that many of them. They have a funny name. They're called crown-like structures because they look like a crown. And they're seen in in normal fat tissue in the body, in excess in people who are obese. And we've recently discovered for the first time that they are present in breast itself. Why does this matter? It matters because these are little engines of very active chemical production, and those chemicals are growth promoters. And what we're, of course, trying to drive ourselves towards is the ability, A, to identify who really is at risk for breast cancer based upon the presence of these structures, and then, of course, ways to intervene to stop the output of these structures. And this is a very exciting and long-term project for us, but only recently it's yielded this very interesting fruit. As I mentioned to Larry recently, we found out this week that this work will be the subject of a major symposium at the upcoming American Association for Cancer Research meeting, and we're very, very excited about where this may lead us in terms of meaningful, practical prevention opportunities for people.